Hello, and thank you for joining us today. My name is Natalie Richardson. I'm Managing Director at Xavier Skin Foundation. I welcome you to today's webinar presentation titled Ocular Melanoma, Innovative Treatments and Beyond. Ocular melanoma is a rare disease. About 200 people are diagnosed in Canada per year. While it represents only 5% of melanomas, ocular melanoma is rapid and aggressive, accounting for 9% of melanoma deaths. Also referred to as uveal melanoma, ocular is an inclusive term. About 90% of primary ocular melanomas develop in the choroid. Recognizing a need for increased support of patients across Canada who are diagnosed with primary or metastatic ocular melanoma, Xavier Skin Foundation has dedicated resources for this purpose to an initiative called Ocumel Canada. In consultation and partnership with global groups Ocumel UK, Ocumel Ireland, and Cure-OM, an initiative of Melanoma Research Foundation in the United States, Ocumel Canada strives to advocate for early detection of ocular melanoma, enable access to early treatment of primary OM, work toward a consistent approach to treatment of metastatic ocular melanoma, and support patients who have been diagnosed with primary or metastatic OM. We endeavor to accomplish these objectives through study of the best practices of large centers in Canada, the US, and the United Kingdom in order to advocate for consistent care of ocular melanoma patients across Canada, particularly those who are in remote or challenged areas not close to Toronto. This webinar is intended as a platform to discuss the current landscape of ocular melanoma treatment options in North America and to identify the most pressing needs for patients touched by this disease. To help us answer the questions that come from the examination of a patient's ocular melanoma journey in Canada today, we are honored to welcome three valued panelists. Dr. Marcus Butler is Medical Oncology Disease Site Lead for Melanoma Skin Cancers at Princess Margaret and is Assistant Professor of Medicine at the University of Toronto. He is the Clinical Director for the Immune Monitoring Team at the Princess Margaret Cancer Centre, where he focuses on the immunologic impact of anti-cancer immunotherapies. We also have Dr. Omid Hamid. He's Chief Translational Research and Immuno-Oncology, Director, Cutaneous Malignancies at the Angeles Clinic and Research Institute in Los Angeles, California, and Director of Experimental Therapeutics at Cedars-Sinai Medical Care Foundation. We also have with us Nigel Deacon, metastatic ocular melanoma survivor and patient advocate, to share his experience with this rare cancer. To facilitate the discussion, we have Kathy Barnard, metastatic melanoma survivor and founder of Xavier Skin Foundation. Before we get started, there are a few things I would like to mention. All participants in the audience for today's webinar will be in listen-only mode for the duration of the session. There will be a question and answer portion at the end of the presentations. You will see at the right-hand side of your screen an option to type in a question under the word chat. Please feel free to ask your questions throughout the presentation, and we will do our best to answer them in the last segment. If there are any questions that do not get an immediate answer, we will contact you via email with a reply and any discussion you may wish to have after the webinar. This session will be recorded and will be a valuable resource that we are grateful to have available for viewing on the Xavier Skin Foundation website and YouTube channel. Thank you again for joining us. We will now begin the presentation. I hand this over to you, Kathy.
Thanks, Nat, and good morning, everyone. I'm honored to introduce Nigel Deacon. As Nat mentioned, Nigel is a metastatic ocular melanoma survivor and patient advocate, and has just recently joined our Xavier Skin team board of directors. Nigel has been instrumental in the creation of Ocumel Canada and has been a valuable support to the patients with ocular melanoma. Without further ado, Nigel, I'd like to hand it over to you.
Thank you, Kathy, and good morning, everyone. My name is Nigel Deacon, and I live in Victoria, BC. I have lived with ocular melanoma for almost 9 years. I was diagnosed with a medium-sized choroidal melanoma in my right eye in June 2010, just before my 62nd birthday, right on cue for this cancer, which tends to strike around that age. I was asymptomatic at the time, although in retrospect, I may have been ignoring little black spots in my vision for some time. Hindsight is always 2020. I was successfully treated with brachytherapy in Vancouver in July 2010. I was referred, as a matter of routine at that time, I think, to the local cancer agency. When I asked about tracking and scanning, I was quite clearly told by the cancer agency that there would be no tracking, as there was nothing to be done about metastasis. I resolved to get on with my life, and I did. However, nature had other plans for me, and metastasis was suddenly diagnosed in March 2012, just short of 2 years after primary diagnosis, after a bout of severe abdominal pain. Several tumors were seen in abdominal lymph nodes and in my liver. Again, I was told nothing useful could be done. The fairly quick onset of metastasis suggested that I had developed a rapid version of the cancer. I was offered dacarbazine at that time. I knew already that it would not help and would just make me sick. So I declined it. I also asked for a new oncologist. I was lucky enough at that difficult time to meet an enthusiastic and encouraging oncologist who is interested in ocular melanoma, and we are still working together. She arranges all of my regular scanning and helps me to access treatment when she can, but at that time nothing was available. In the meantime, though, I sought help near and far and met a very compassionate oncologist in North Vancouver who was able to arrange for me to get in on the very end of compassionate access to the first immunotherapy in the fall of 2012, just before it was officially approved in Canada. Subsequent scanning showed no apparent response and an increase in tumor burden, so I was asked to register for hospice in January 2013. By April 2013, though, a mixed response was evident from scanning. A second round of the same immunotherapy, as advised by experts in Philadelphia, and provided by the local cancer agency, as it had just been approved in the fall of 2013, was augmented with radiation to the abdomen, and the response was even more mixed, with some tumors dying and some growing. A third round of immunotherapy in 2014, denied by the local cancer agency, but provided by the pharma company after welcome advocacy and support from Savior Skin Foundation, led to even more progress. But in the fall of 2015, more severe pain led to the discovery of 2 new tumors near the kidneys. Additional radiation to those tumors led to 1 tumor shrinking, but the other still growing. A fourth round of immunotherapy in 2015 and stereotactic radiation in the summer of 2017 to the last stubborn tumors has led to all tumors being stable or shrinking, and that is where I am now. This stability has been shaping up now since June 2018. I have no idea, of course, what the future has in store for me. I try hard not to think too much about that, and I realize how very lucky I am to be in this situation. During all of the time since my primary diagnosis in 2010, I've struggled a lot to try and keep my anxiety under control. In addition to the cancer, I've had personal challenges that might or might not be related to my cancer status. In some ways, my biggest, hardest struggle has been just to enjoy life from day to day. Cancer threatens all aspects of our well-being. In retrospect, My memory is of a time of continuous frantic worry. During all of this time, from 2010 to now, and more intensely, of course, since 2012, I've learned a lot about this cancer. I know how rare it is. Treatment of primary tumors is almost always successful in killing the tumor. Treatment of metastasis remains a big problem. I always felt during those years that I was losing ground, and it was very challenging to be arranging my own care through multiple centers. I just didn't know where help would come from when I next needed it. I've spent a lot of energy, time, and money on building an international network of support. What helped me most through that difficult time was professional people who knew how to help and a host of friends that I leaned on heavily. Of course, there's still currently no approved treatment for metastasis. I know from helping others on their journey that some people across Canada and in my home province of BC are still not getting the kind of care that is wisest after a primary tumor. We can do better, and people can live better and longer. This is a time of hope that we can make a breakthrough with this difficult and rare cancer. It's a time to focus and organize. This webinar is an encouraging sign that the required focus will now sharpen, and ocular melanoma in the event of metastasis will no longer be considered a hopeless scenario. The report that we developed in 2017 indicated that Canadian ocular melanoma patients often struggle to get appropriate and helpful, timely information. They struggle to get treatment close to home, and they often find themselves financing their own care expenses. I'm hopeful we can all work together to do better. Thank you very much for listening to my story.
Thanks, Nigel. And let's move right to our experts on the webinar and see if we can find the future in store for you. So I'd like to take a couple seconds just to introduce Dr. Butler. Dr. Marcus Butler is a physician investigator with an interest in the translational development of immune-based therapies for cancer patients. Dr. Butler has been involved in the early development of several important immune-based therapies for cancer, including adoptive cell therapy and immunomodulators, including immune checkpoint blockade. He has a major interest in investigating the combination of standard and immune-based therapies, as I mentioned, to address innate and emerging resistance to immunotherapy. And I'd like to hope to say that Dr. Butler is a good friend of the Savior Skin Foundation. Dr. Butler, over to you.
All right. Well, thank you very much for the opportunity to speak today. So I'm going to start with, with just an overview of ocular melanoma, focusing on uveal melanoma. Okay. I do have some disclosures. I've served on advisory boards for these drug companies, and also I have research funding from Merck and Takara Bio. What is the uvea, or the source of uveal melanoma? The eye is a structure that has three main layers. The white part of the eye, or the sclera, is on the outer layer. And then we have the choroid, which is in between the retina, where the light sensing organ, and the sclera. That area is called choroid and contains pigmented cells. So on the left, you can see this sandwich approach, and then you can also see the lens and the iris, where the light enters into the globe. On the right, is a cross-section of the eye, and it shows that the uvea, the uveal tract, contains cells that are part of the iris. The ciliary body is the part of the uvea that's right behind the iris. And then the choroid is the uvea that's behind the retina in the back part of the eye. So uveal melanoma is a rare condition. It's the most common type of cancer in the eye. There are also conjunctival ocular melanoma, which is a separate type of cancer which has different properties. In terms of the incidence of uveal melanoma is between 2 and 6 patients per million per year. In Europe, the incidence is much higher in northern latitudes, around 6 patients per year, and in the south of Europe, it's in the 2 patients per year. In the United States, there isn't this geographic difference. The diagnosis, and actually I wasn't able to find any information regarding Canada versus United States. That might be an area of interest to research. In terms of diagnosis, as Nigel mentioned, the average age is 58 to 61, and there's a plateau of the diagnosis in patients in their 70s. However, there are people that are young, children can develop uveal melanoma, as people who are quite old. It is more common in patients with lighter skin, and dark skin races, it's a rare condition, although it does occur. The impact is equal between men and women. It's not a cancer related to ultraviolet light, and therefore it doesn't have a UV signature, and it's not due to sun exposure. And then finally, this is usually not a hereditary disease. However, there is a BAP1 mutation that's found in some families that can result in a higher incidence of uveal melanoma. Now, the 3 types of uveal melanoma are melanomas that arise from the iris, from the ciliary body, this area behind the iris, and choroidal melanoma. The choroidal melanoma, or melanomas of the back of the eye, are more common compared to the iris and ciliary body melanomas. The iris melanomas tend to be diagnosed earlier, so these conditions are usually, the lesions are smaller, associated with a better outcome, and the amount of recurrences that occur within 10 years is only 5 to 6%. The ciliary body, which is an area that's not usually noticed by someone who has a tumor that involves the ciliary body, because it's behind the iris and therefore it's not obstructing your vision and can grow larger before it's diagnosed. These are often undiagnosed until they're large, and it's often comprised of that epithelioid cell type, which is a higher risk type of cell. And in 5 years, about 25 to 50% of patients will have recurrence. The choroidal melanoma, the back of the eye, has a lower recurrence rate for the first 5 years. However, all of these melanomas can recur with metastases late, up to 15 years after diagnosis. The symptoms are usually the symptoms of choroidal melanoma or uveal melanoma is usually due to obstruction in the vision. It usually presents, this disease presents in one site, which is fortunate in that if you need treatment where the eye is lost, you have your other eye survive. And the symptoms depend on the location, but often involve flashes of light, retinal detachment floaters, or some sort of sensation. In terms of metastases, unfortunately, 50% of patients will eventually have metastasis. The most common site is within the liver, and many times patients will have a bulky tumor in the liver, but not elsewhere. There's also metastases possible in organs like the lung, skin, bones, or GI tract. The biopsy is not required for diagnosis, so a lot of patients with uveal melanoma will present to an ophthalmologist, and then they will be referred to an ocular oncologist who's able to examine the eye with an ultrasound or assessment and can measure the eye and to get dimensions, also perform fluorescein angiography, and then come up with a treatment plan that does not require tissue. However, tissue may be helpful in analyzing, doing additional analysis, providing patients with risk stratification. The types of local therapy for eye melanoma there are several different approaches, and they are highly successful in controlling local disease. Radioactive plaque or brachytherapy is the most common method for treatment, and it is highly effective. Other strategies include external radiation, enucleation or eye removal. There are some cases where laser thermotherapy can be performed, especially if the iris is involved. And then in limited cases, just resection of the tumor is possible. In terms of brachytherapy, this is a procedure where a gold plaque is filled with radioactive beads and then placed next to the tumor. So if you have an eye, a choroidal melanoma shown at the lower right-hand figure, you can place the plaque radioactive beads right behind the eye that the surgeon places. And then for 5 to 7 days, radiation dose is delivered to destroy all of the tumor cells. And then the plaque is removed and the patient is monitored. This allows for intensive radiation at the site of the melanoma and is highly effective. 95% of cases will be controlled or have no evidence of recurrence at 5 years, and most of these cases beyond that period of time. External radiation is an option for patients who are unable to undergo this invasive procedure requiring general surgery. Also, if you have a tumor that's right over the optic nerve, it may not be possible to perform plaque therapy, and therefore external radiation can be considered. And also, if a patient has a recurrence after plaque therapy, external beam radiation can be used. Removal of the eye is also possible, especially for large lesions that you're unable to radiate. If there's a failure of radiation, enucleation can be performed. There are some patients who have complications with prior radiation, and removal of the eye might be necessary. But previous studies have shown that enucleation and radiation have similar survival rates, and for most ocular oncologists, the irradiation schemes are used as the first line of defense. So, as I mentioned, there's a high rate of recurrence, but a lot of people also don't have any recurrence. So there are different approaches that are currently being used in North America and Europe for identifying patients. The first, most basic strategy is to look at the size of the tumor. Small tumors, less than 2.5 millimeters thick and relatively small at the base of the tumor, have a mortality rate of 1% at 5 years. Median sized tumors have an 11% mortality rate, and large tumors have a 27% mortality rate. However, there are examples of patients who have small tumors that still relapse and large tumors that don't. Another strategy that shows, or this slide is the current classification scheme that we use, call it a AJCC classification scheme. And this will increase your risk level if you have ciliary body involvement. And as you can see in the lower curve, the percentage of people surviving over time is shown, and that the higher stage lesions have worse outcomes compared to lower stage lesions. In general, stage 1 and 2 are limited to the eye. Stage 3 is in the regional area of the eye, and stage 4 is distant spread of metastatic disease. Another factor that impacts recurrence is the type of cell that's present. Spindle cell is a more common type of of ocular melanoma, uveal melanoma, and its recurrence rate is much lower, only 20% compared to epithelioid, which carries a 15-year recurrence rate of 75%. Now, a lot of areas use different approaches for obtaining risk stratification. And all of these require tumor tissue from the time that the patient presents for their treatment. So the only way currently for stratifying beyond the staging is to obtain a sample of this very tiny tumor that's in the eye. And what ocular oncologists do is that at the time of the surgical procedure, with the insertion of the plaque brachytherapy, for instance, a needle is passed through the eye into the tumor, and a group of cells are obtained that then are sent for analysis. And there are two main types of analyses that are being investigated or being performed currently. And this is based on a recognition that chromosomal abnormalities are associated with an increased risk of recurrence. Chromosome 3 is a chromosome where the BAP1 gene exists, and in patients who lose one of their chromosome 3 in the uveal melanoma, those patients have an increased risk of recurrence. There are also known mutations that are present within the uveal melanoma. GNAQ and GNA11 are very common mutations. They're mutually exclusive, so you have one or the other. And these are driver genes that are involved with early growth of the uveal melanoma and are very common to all of these tumors. BAP1 is a mutation that's associated with early metastasis. EIF-IAX is actually a mutation that portends a good prognosis. And FF3B1 is an interesting mutation in that it's associated with late metastases. So patients with this mutation in their tumor will frequently do very well for several years, 3, 4, 5 years, and then have an increased risk of metastasis development. All of these mutations, however, are usually what we call somatic mutations. They occur in the tumor cells themselves, and they're not passed down through the family. So even though you might be told that you have a mutation in your tumor, it doesn't mean that your family members are at risk of having a uveal melanoma by way of the mutation, unless you're told otherwise. So what can we do with this information? As I mentioned, the monosomy 3 is associated with a higher risk. BAP1 mutations and these other mutations, as well as high stage, are associated with a higher risk. At Princess Margaret, we're currently intensively monitoring these patients with imaging every 3 to 4 months. And for patients with lower risk, including patients with stage 1 disease, but no genetic abnormality, or with medium stage but low risk genetics, these patients can be followed by ocular oncology and their family doctor for monitoring for evidence of recurrence. There is also another type of test that's very commonly used in the United States. The Castle test is covered by most insurance companies, but is in Canada is usually not covered. This is also called DecisionDx-UM. This is a test that looks at the expression profile. It's the type of proteins that are expressed within the tumor that's in the eye. And the 5-year recurrence rates are very low for class 1A, a little bit higher for class 1B, and quite high for class 2 expression profiles. There's an additional gene, PRAM, which is associated with increased risk of recurrence, and the Castle test has the option of including this test in addition to the standard profile. So despite excellent local control, as I mentioned, up to 50% of patients develop distant spread. And usually this involves metastasis in the liver. and unfortunately, chemotherapy has little benefit. In terms of screening, what we often will do, especially when we're looking at a 15-year timeline for monitoring patients, is that once we know that the patient has no evidence of problems outside of the liver, we'll monitor patients with liver scans only, and we'll do additional scans if the patient develops other symptoms. MRI scans of the liver have been shown to be probably the best strategy for picking up early disease. CT scan often will miss small lesions within the liver, and ultrasound is not quite as good as MRI, but if you're unable to tolerate an MRI scan, a CT or ultrasound may be appropriate. In terms of adjuvant studies, so these are studies that are designed to try to prevent recurrence. We currently don't have any studies open in Canada looking at this approach, but there are studies that are being investigated in the US and in Europe with the hope of identifying a way to reduce the chance of recurrence. These types of approaches require large numbers of patients because many of the patients are actually cured that participate, and you need to, in order to see a significant difference, we need large studies. And that's because when you develop metastatic disease, unfortunately, as Nigel mentioned, the overall survival is not good. More than half of patients pass away within the first year, and at 5 years, the vast majority of patients have passed away. However, as you notice here, at 5 years and beyond, there are always some patients who do well, and you never know whether you're going to be that patient or not. And the main thing that we really need to look at is to try to understand why some patients do better than other patients, and try to develop treatment plans so that the right strategy can be obtained for all patients. One approach in patients who develop disease is to provide liver-directed therapy. This is appropriate for patients who have disease that involves the liver only and not significant bulk outside of the liver. The reason for this is that if you have liver predominant disease, then if you're going to have most of your symptoms due to liver progression or liver failure, if we can get a hold of or control the disease within the liver for a period of time, that can provide patients benefit. This approach also allows us to deliver high doses of treatment to the liver, which otherwise might not be possible with systemic therapy. The types of liver-directed therapies include drug-eluting beads. Some of these include chemo on the beads or immunotherapy drugs on beads. There is also the strategy of radioactive beads that can be infused, and then arterial administration of chemotherapy through a TACE procedure. And the liver-directed approach is something that's investigated across Canada and North America, but I think it's also important to know that there aren't a large number of systematic clinical trials with liver-directed therapies, so that sometimes it's a bit of a challenge to get drug funding within the Canadian context. So in summary, uveal melanoma is typically diagnosed clinically. You don't need a biopsy in order to provide treatment. However, a biopsy is very helpful for stratifying and figuring out the risk that patients have and how intensely they need to be monitored for recurrence. Local therapy is highly successful, so it's a disease that is very sensitive to high doses of radiation, and that's a fortunate aspect of this disease. Testing at the time of diagnosis is necessary. Unfortunately, if you deliver the radioactive beads and don't obtain the biopsy for assessment, there's no possibility of going back unless you develop the tests later on where tissue can be analyzed. So if you're interested in knowing your prognosis, the biopsy procedure at the beginning is necessary. The optimal monitoring program is really in discussion. There aren't clear guidelines, and different groups are taking different approaches. Our approach at Princess Margaret is to investigate and monitor patients at high risk with liver MRIs, and in order to identify patients early so that interventions can be performed, such as liver-directed therapy, surgery, or radiation, and then as well as systemic therapy that Dr. Omid's going to discuss momentarily. Thanks very much.
Thank you very much, Dr. Butler. Now I'd like to introduce Dr. Hamid. Dr. Omid Hamid, MD, is the Chief of Translational Research and Immuno-Oncology at the Los Angeles Clinic and Research Institute. He also serves as the Director of the Melanoma and Phase 1 programs. His areas of expertise include immunotherapy and Phase 1 drug development. Dr. Hamid has published extensively and has been at the forefront of the development of paradigm-shifting breakthroughs, including BRAF, MEK, targeted agents, anti-CTLA-4, anti-PD-1, and PD-L1 therapies. His current interests include new immunotherapeutic options for patients, including bispecific antibodies, adoptive T-cell therapy, and oncolytic therapies with a focus on combination approaches resulting in potentially greater patient benefits. So without further ado, Dr. Hamid, over to you.
Hi, thank you so much. Can you put up my slides, please?
Okay, would you like to? Okay.
Or do you want me to place them on mine?
If you wish to, I can bring them up. It's up to you.
Can you please bring them up and I'll...
Absolutely.
Okay, so thank you so much for the opportunity to speak on this very important topic. You know, we've in the States had multiple issues with the ability to move the field of treatment for metastatic ocular melanoma forward. Partly that is due to the fact that ocular melanoma is a very hard tumor to treat, but partly due to the low numbers of patients and the difficulty showing a treatment benefit. You know, if you want, I'll just put up my screen here. All right, let's see that. Can you see that?
I'll change it to that was my screen there, so it's over to you. There you go. We can see that. So if you just there, perfect. Thank you.
So, so this is the Angeles Clinic in LA. If you're ever around, please stop by and say hello. My contact information is there, and we'll show it again at the end. These are my disclosures, as we've been searching for a great partner to help us to answer these questions. So as you no doubt heard, there's been great progress in therapies for cutaneous melanomas, and the first place we go to look for those options for ocular melanoma is what has happened in the field of cutaneous melanoma. So PD-1 blockade now is considered first-line therapy for cutaneous melanoma, but as you can see here, it does and has shown responses in patients with ocular melanoma. This is a patient with pembrolizumab who has a liver lesion, lung lesion, bony lesions, and subcutaneous lesions that seem to have responded, and even those with poor prognostic indicators. So immunological checkpoint blockade in uveal melanoma has been there even with anti-CTLA-4 as far as ipilimumab and tremelimumab, and then Pembro, Nivo, Atezo, the other PD-1 inhibitors. Unfortunately, case series have been small, and response rates have not been as durable as one would want, with a short progression-free survival and overall survivals that sit around what is standard 6 to 9 months. You can see here ipilimumab and pembrolizumab. So we've moved from that, as we have in cutaneous melanoma and mucosal melanomas, into looking at combinations of nivolumab and ipilimumab. And this is a study that was recently presented at ESMO, metastatic uveal melanoma. You can see here the patients are standard patients. The majority have liver metastases, and extra liver metastases have been there. You can see, as we have talked before, the complete response rates were not there. Partial response rates were seen in 6 patients, 11%, but the idea of stability and durable stability was seen there, giving disease benefit, what we call disease control, which is those who respond and those who have stable disease greater than 50%. What has been interesting here is, although the progression-free survival has been short, and when you look at this, the overall survival in these 52 patients and compare it with historical controls with all of the pitfalls that brings, you can see here that we're moving the median overall survival up to a year. Although that isn't phenomenal, this is a comparison that's taken from the majority of the most recent trials that were done, including the Richard Carvajal selumetinib MEK inhibitor study. So we are finding an indication about where we can go with checkpoint inhibitor. So why doesn't checkpoint inhibitor work as well? Well, we've all been told that those tumors with high mutational burden respond to immunotherapy, and that's where melanoma as a whole sits. But unfortunately, uveal melanoma sits way below. So our ideas will have to be to improve the response. Well, how about using PD-L1 as a marker? This is a staining that we do to see how much PD-L1 is there, and that's been indicated to correlate with high response rate. And if you can see in cutaneous melanoma, while PD-L1 expression is high in multiple areas of tumor involvement, it's not so in uveal melanoma, especially in the liver, where it's extremely low. Additionally, data that's come from prospective and retrospective evaluation of patients treated with cutaneous melanomas has shown that patients who have liver metastases, despite the amount of disease or the other areas of disease or any other correlatives, they have a lower response rate to immunotherapy. So our program here is working to try and figure out an answer to that. That begins with an understanding about tumor-infiltrating lymphocytes. And in short, this busy slide tells you that the majority of CD4 and CD8 T cells that you need are not there in metastatic uveal melanoma. And this is important not only for this tumor, but many other tumors where we found that lack of response is indicated by not having T cells in the tumor to begin with, and therefore our idea should be to find a way to bring those tumors in. Well, let's talk about other things and get back to the checkpoint story. Adoptive T cell therapy is a therapy where you excise tumor, you put those tumor fragments on a plate, you culture and you grow and find those T cells in the tumor. So this is tumor, these are T cells. And then you select and expand those tumors into those T cells into the billions, and you reinfuse into the patients. And this is a standard option for patients with cutaneous melanoma and other solid tumors such as cervical cancer, and is being looked at lung and other cancers. And when you look at it, an early phase 2 trial of adoptive T cell therapy in uveal melanoma in patients treated has shown about a 35% response rate. Well, you can look here on the spider plots and you can see some very early responses, some very deep responses, a person here going on to a complete response and continuing. And if you look in the x-axis for time, you can see durable responses that are there. Response duration is 21 months and above. And why this hasn't really taken a great foothold is the problem of finding those T cells in those tumors, because very few of the tumors that you resect in ocular melanoma will grow out these cells to the number that you will need to reinfuse. But it's a beginning. And what we're doing at Angeles through a collaboration with Iovance is doing this in other solid tumors where you don't need the facilities. You can send the tumor out and have the T cells sent back and infused at your local institute. The superstar of ocular melanoma at this point is IMC-GP100. And this is a drug that I call like a Yenta antibody. It's a matchmaker. And it's an antibody that's bispecific. It's got dual sides. One side targets the tumor cells. The other side targets the T cells. So as you can see here, the cancer cell itself has GP100. This is the bispecific itself. It targets GP100. And the other side targets CD3 found on the T cells. And this connection, this matchmaking ability allows the T cell and the cancer cell to come together with a close synapse, the T cell to be activated and release lytic granules to kill the tumor. And you can see here that this is a way to stimulate a non-active immune system to recognize tumor cells and go forward. What's become so interesting about this is that in the first in-human studies where we looked at uveal melanoma patients with significant liver involvement and being treated, and in the current study looking at ocular melanoma, we are seeing significant progression-free survival, stability of disease, significant one-year survival rates, now at 73%, and those patients who an overall survival not reached, and those patients who are having response doing well. What you can get from this is that there is some activity here, and the FDA here in the United States has granted this an orphan designation. There are currently 2 trials ongoing looking to get FDA approval for this study. The first one is a first-line study ongoing comparing randomization for untreated metastatic ocular melanoma to this bispecific antibody versus a PD-1 inhibitor. The second is a second or third line therapy trial, which is fully accrued, and we're awaiting some early data coming. I wanted to put this here to compare the one-year overall survival rate seen here with IMC-GP100 at 73% to what we're really seeing with some case reports with immunotherapy of 40%, and I showed you the ipi-nivo 40%, and then ipilimumab 22%. So it's an interesting idea to build off of. If you go back and you look at this antibody itself, it's currently being looked at in combination with anti-PD-1 therapies and anti-CTLA-4 therapies, and also a triplet combination of anti-PD-1, anti-CTLA-4, and cutaneous melanoma. But what that tells us is that what we've seen early is these combinations are tolerable. And the next steps would be to try to bring these combinations in. In addition, we're going elsewhere and looking for other immune modulatory checkpoints. As you've all seen before, there are checkpoints that turn up the activating of a T cell, like a gas pedal, like pressing on the gas pedal. And then there are ones that block the inhibition, and we know CTLA-4 and PD-1, so this is like cutting the brake off. And all of these antibodies are now available in the clinic, and not all, but most programs are allowing in their phase 1 portion the ability to enroll uveal melanoma patients into their studies. Additionally, and what is the most interesting, is that there are now approaches to deliver these immune therapies directly into tumor. As you saw before, Dr. Butler showed you the liver-directed therapies with chemotherapy and other. We now have the ability to give directed therapy into visceral lesions, including liver lesions, through multiple clinical protocols. We at this time are looking at STING activators, CD40 antibodies, and and others with direct injection in the liver. Oncolytic therapy, which is viral therapy that has been approved for cutaneous melanoma, is now being looked at through multiple clinical trials through Amgen for hepatic liver-directed injections. And these can be combined with pre-existing checkpoints like PD-1 and anti-CTLA-4. As I come towards the end of my talk, I do want to bring forth the idea of getting data from trials that have somewhat not met the right endpoints. This is selumetinib versus temozolomide. Rich Carvajal presented this at ASCO, and an updated randomized study has recently been presented that showed no real survival advantage, a higher response rate. But when you see these the responses with selumetinib in patients that have the GNAQ and GNA11 mutations, these initial responses, although not durable, showed a response and an idea that has now been moved forward into multiple solid tumors, but is an option for ocular melanoma. Blocking MAP kinase signaling through MEK inhibitors can enhance tumor cell death, can activate T cells, and can bring in immune cells into tumor. What this busy slide shows is what we can show here in patients that were treated with a similar MEK inhibitor and then given PD-1. Giving MEK inhibitor here, just giving the MEK inhibitor increases CD8 T cell infiltration. You can see these brown marks here. Increases MHC class 1 expression, the way that the tumors can interact with the T cell, and increases PD-L1. And you can see these are the things that we began our talk with, that uveal does not have this, uveal does not have this, but you can clearly sort of stimulate that with a MEK inhibitor. And then in this study that was presented multiple times, giving a PD-L1 inhibitor increased that significantly further. So these are options that we're looking forward in our clinical trials. I would like to also bring a thought that was presented by Rich Carvajal and others. This is a patient with youth metastatic ocular melanoma who got ipi-nivo and responded, and 6 months after just receiving ipi-nivo continues to benefit. And when you look at the history, prior therapies have failed anti-CTLA-4, failed anti-PD-1, and radioembolization for local therapy, were treated by our bispecific for 20 months, and then received repeat checkpoint. And so the question really is have we just proven what we've been talking about for the whole part of this discussion, that you can use another type of immunotherapy, whether it's alternate checkpoint, whether it's targeted with a MEK inhibitor, and really bring T cells into tumor that would allow you to reinduce checkpoint and then receive a response like this lovely 52-year-old female. And that indicates that possibly the best is yet to come. As I end, I will say that there are adjuvant clinical trials in some stages coming forward. They're very early, and they are looking pretty much at high-risk patients. It's difficult to find, and some of these have really not shown any evidence of benefit, but that is another place that we're looking. So despite our roadblocks in the past, the field of immunotherapy and targeted therapy for all solid tumors is evolving, and these benefits can be related to future therapies for metastatic ocular melanoma. As I come to an end, I want to thank you for your time, and we'll give over the control of this teleconference back to Kathy Bernard. It's a pleasure to work with people like Dr. Butler, Natalie Richardson, Ms. Bernard, and of course, a pleasure to have met Nigel and to be part of his treatment team.
Thank you so much, Dr. Hamid. We're going to hand it back over at this time to Nat. So if you have any questions, Nat will be taking care of you.
And thank you very much, Dr. Butler and Dr. Hamid. It's fascinating that your centers are doing, and we very much appreciate hearing about it. We do have a couple of quick questions. I know we're very close to time, but first question is, what scanning frequencies and which kind of scanning are recommended for which patients? And Dr. Butler spoke to this a bit already about Princess Margaret, but Dr. Hamid, what's happening in your area with scanning frequency recommendations?
Yeah, we really, again, the same as Dr. Butler, look every 6 months to image. For those who have had recurrent lesions that have been resected then more frequently, the question also becomes, what are the opportunities? And in some of our patients who have ocular melanoma and high risk, where we've resected or we have concerns, if an opportunity is there, we will work to be aggressive to image if they can meet those inclusion criteria. These trials, although they are more frequent, are less frequent than we would like, and we'd like to get them through those sliding doors.
Thank you. Okay, and to either one of you, Dr. Butler or Dr. Hamid, is radiation in any of its forms useful for controlling liver metastases?
This is Dr. Butler. Yes, I think it is useful in controlling metastases, and it really depends on the geometry of where the tumors are and what can safely be administered, and also depends on whether the disease can be controlled with this approach. There are some cases where there are just too many lesions and radiation is not really in the patient's best interest.
So I would also say that there's a lot of data about the synergism of radiation with immunotherapy, the ability of radiation to elicit MHC increase, and the ability of it to push patients who are not having optimal responses to immunotherapy further. We utilize radiation for patients who have difficult hepatic lesions from time to time. So I'll say it's an early start to a modality that will have a significant use in the future.
Interesting. Okay, thank you. I do, in the respect of the time of our panelists, I will have to wrap up, though we have a couple more questions. I will follow up with you by email, and we'll try to get some answers for you. Again, all of us at Save Skin and Ocumel Canada would really like to thank you for your time, Dr. Butler, Dr. Hamid, and Nigel. This has been a valuable presentation. Thank you very much. And thank you to everyone for attending today's webinar session. If there are additional questions, please send them to myself at natalie@saveyourskin.ca, and we'll get back to you. Thank you for watching. This ends the webinar session.
Great, thank you very much.
Thanks, everyone.
Guys, thanks for the opportunity. Have a great day and great weekend.
Thank you.
Yes, you too.